Good evening, everyone, and thank you for joining us tonight for our inaugural Migraine State of the Union broadcast. I'm Dr. Lawrence Newman, Chair of the American Migraine Foundation, and I can actually think of no better way than to close out Migraine and Headache Awareness Month by having my colleagues talk to you about where we are and what the future of headache medicine will be, hopefully. Clearly, we've picked a good topic because over 900 people have registered for this webinar tonight. As you can see on your screen, I'm joined by three internationally recognized thought leaders who have devoted their careers to solving the mysteries that surround migraine and caring for the people who live with this disabling disorder, and as well as advocating both on the professional side and the patient side as well. I don't want to give too much away about what they'll talk about, but I've asked the participants to talk a little bit about the current migraine landscape as it relates to treatment, to research, and to advocacy, as well as to opine about the future of headache medicine for us as clinicians and for our patients as well. Before I introduce tonight's speaker, I just want to spend a couple of minutes talking a little bit about the American Migraine Foundation and what we've accomplished over the last year or so. For those of you who haven't attended any of these webinars before and haven't gone to our website, I encourage you to do so in the future. But let me just tell you that the foundation is built upon four core pillars: education, support, advocacy, and research. And I can tell you that all of the projects that we develop and all of the initiatives that we have keep those pillars front of mind as we develop our programs. Over the last several years, we've continued to evolve our Move Against Migraine campaign, and we're now capable of delivering not only regional, but national and even global programs. We're focusing this year on several initiatives, that being diversity, equity, and inclusion, employer-employee engagement, pediatric headache disorders, outreach to underserved communities, as well as patient advocacy. We've recently chosen a new board of directors. We had our first meeting in April, during which time we ratified our bylaws. The core exec of the American Migraine Foundation includes three of the people on the screen today. So as I had mentioned, I'm the current chair. Dr. Christine Lay is the vice chair, and Dr. David Dodick is the founder and past chair of the foundation. We have a secretary, Debbie Henshine-Lorenz, and our treasurer is Dr. Ken Schubenstein. Our executive director, who keeps us in line, is Ms. Nim Lolvani. If you look at our website, and I encourage you to do so, you'll see the bios and pictures of our new board of directors. We've made significant inroads in trying to put together a rather diverse board of directors. You'll see, besides representatives from the American Headache Society, including Dr. Goadsby, who sits on our board, several others from the American Headache Society are also on our board. We have a patient advocate. We have a prominent media correspondent, a successful business entrepreneur, as well as a person with a passion for working in the pediatric and adolescent communities. Several of us on the board live with migraine ourselves or have family members who live with migraine. One of us on the board actually lives with cluster headache. For the last couple of years, we've had a spokesperson in Mr. Jim Kramer, who's the host of a syndicated show on television, Mad Money. And if you've seen him, he's a rather engaged, vocal, and tireless champion of the foundation. And at least once a week, he has a shout out to what we're doing. Currently, looking at our membership, we have over 130,000 public Facebook followers. There's more than 27,000 members in a private Move Against Migraine group. And we have over 80,000 subscribers and contacts to our website. For those of you who haven't already joined, or for those of you who know people that should join, we encourage you to have them sign on, because the more numbers we have, the more people we can advocate for, and the strength we have in that advocacy. So with that, let me just introduce our three speakers tonight. We have Dr. Peter Goatsby, who's the current president of the American Headache Society, and as I've mentioned, sits on the board of directors of the American Migraine Foundation. Dr. Goadsby is a professor of neurology at UCLA in California. And besides being a superb clinician, he's an accomplished researcher with his major interests centering in the basic mechanisms of primary headache disorders such as migraine and cluster headache, both in the experimental and clinical settings. And he uses this to translate these insights into better management for patients. And to that end, Dr. Goadsby was just awarded the prestigious Brain Prize from the Lundbeck Foundation, which is basically a Nobel, the equivalent of the Nobel Prize for neuroscience for people who have made groundbreaking contributions in the field. Dr. Goadsby's award was in recognition for his work on CGRP, which was instrumental to the discovery of many of the new medications that have just come out on the market for our patients. And I can think of no one better suited to discuss the current migraine treatment landscape. Discussing with Dr. Goadsby will be Dr. Christine Lay, who's the vice chair, as I had mentioned, of AMF. Dr. Lay is a professor of neurology at the University of Toronto, and she's the founding director of the Center for Headache at Women's College Hospital. She serves on the board of the American Headache Society as well as the Canadian Headache Society. She is a tireless advocate for patients and an excellent clinician and researcher as well. And we also have Dr. David Dodick, who is the founder and Immediate-past Chair of the American Migraine Foundation. Dr. Dodick is a professor of neurology at Mayo Clinic College of Medicine and a consultant in neurology at the Mayo Clinic in Scottsdale, Arizona. He's also a past president of the American Headache Society and a program director at Mayo Clinic Neurology of the neurology program there, as well as the Headache Medicine Fellowship Program. So what I'd like to do is just open the mics up and ask the three of you to participate in the State of Union. So I think we'd start with Dr. Goadsby and Dr. Lay just to talk a little bit, and Dr. Dodick, feel free to weigh in on the current state of where we are in the migraine treatment landscape, research, advocacy, etc. And I'm going to mute myself so that I don't echo.
Would you like to start, Peter?
I was going to be polite. But let me start by thanking Larry for a very generous introduction, and in his usual way, he summarised everybody else and everyone's contribution, and characteristically left out his own as past president of the American Headache Society and now the chair of the AMF. A remarkably engaging chair in all things. I remember when he was president of the AHS. But people would do everything that Larry asked, not because they necessarily wanted to, but because he's such a great guy. Who says no to Larry? There's another person in our field where people don't say no, but that's because he keeps pestering you. Larry's just like 100% good guy. So I think that I'll just acknowledge at the start. There's four of us in this, not just the three of us. It's certainly an exciting time in headache. It doesn't seem like only 3 years ago since the first of the CGRPs were approved, because we kind of last year was a bit of a wash, you might say, and then the GPANTs and the DITANs. It's extraordinary after not seeing much really happen in a kind of in a sort of quantum way to see the development of new therapies, both for the prevention and the acute treatment of migraine, and now these overlap therapies that will both treat migraine preventatively and have an acute action. As a clinician, it's just fantastic to be able to say to people who you've had to look at, scratch your head, and you can see I've scratched my head a lot over the years because everything fell out doing it. Finally, we have things that we can really do. So I think it's really exciting. I just can't think of a more exciting time in my life. I think that must be something you feel in your practice, Christine.
Absolutely. I think it's been a game changer, I think, as you had said. And I think what I say to patients is, for many years we had to say, I'd like you to try this medication, and it really wasn't developed for migraine, and I really don't think you have high blood pressure or seizures or depression, but it will work for your migraine because of other reasons. It was a long discussion. And now we have the opportunity to make the diagnosis and then say to patients, I have targeted therapy for you. I have a medication for you that was developed to treat migraine. So it's just an entirely different discussion, and it's exciting.
I'm struck by the people I've started on these medicines who failed like 9 different things. And I'm always been an optimist. I don't think you can be in medicine in a disorder like look after people with sort of like migraine, who are all heroes in my view. I mean, they're just people come in and they kind of just get on with their lives, although they have to very often struggle through them. And you start someone on these new medicines and they work. I have to say the first couple of people I saw in whom I didn't really expect much to happen when it worked, I think I was less believing of the outcome than the person sitting in front of me. I remember the first few. It's incredible when you can turn someone's life around. It's very rewarding.
For sure. And I think one thing, and David and Larry probably found the same, that patients have said, I forgot what it was like to have a headache-free day. I used to think I had headache-free days, but now I really, truly know what it's like to have a day where I'm completely free of migraine in those in between, more severe attacks. And so that's been a common thread I think we've heard from patients.
This concept of being crystal clear. If you don't have headache, then you kind of clear all the time. You can shake your head about and whatever. But if you have a difficult migraine problem, it's never quite exactly on the money, 100% in terms of either pain or cognitive dysfunction, this sort of cloud that goes over people. And if you can get rid of that, it's a spectacular difference. It's funny how, funny is not quite the right word, but it's remarkable how the symptomatology, the verbiage, the words we use are fairly subtle words, and we say, oh, cognitive, but the dysfunction that results from those fairly subtle words is quite profound. And then when you turn it around and people go, oh, good Lord, life is, I've got normal days. So it's very rewarding, very rewarding.
Mm-hmm. I think the
I think
challenge
we've got
now
more
is
things to come
Yeah.
on the research side. I mean, the other thing I always say to people that whatever's happened, even if everything doesn't work and everything we have today doesn't work, there are people in the laboratory, there is a tomorrow. And the current batch of things proves that there was a tomorrow, because 3 years ago there was yesterday. So there was a tomorrow, and there'll be more tomorrows, I think.
I think there's incredible research that's going on, and I think it's important for those patients to have hope, to not forget about perhaps this current drug didn't work, but other ones will.
That's right. So I mean, I live in a world of optimism.
Yeah.
Unfortunately, Larry, we can't hear you.
I'm not sure.
Now do you hear me?
There you are.
It said the organizer had muted me, and I thought I was the organizer, so that was very disappointing.
That's what you get for being the chair. That's what you get for being the chairperson, doesn't it?
Yes, I guess so. So
all responsibility and no unmute button.
So since we're talking to a group of patients out there, and it's clear that for many people this is a game changer. I mean, you've mentioned it. We've all seen in our practice that it's changed the conversation in the office. Rather than spending 30 minutes about pontificating about what could be used, or what we can change their medication to, the medication is, so how's your family? What else is going on? It's wonderful. These people come in saying it can be life-changing. But I think our audience needs to realize it's not a panacea. They don't work for everybody.
Oh, yeah.
And if it doesn't work for them, it's not that they failed. It's that the medication failed them. It's not that it's their fault. So since we have 900 people online who want to know, so what do you say to them if they come in after you've tried one medication? Do you try another one? Do you give up? I know nobody on this line gives up, so I can ask it that way. What do you do?
I think we don't give up. And as Peter said, these are patients who have hung in there and determined to have a lot of courage and strength to keep going. I think, sometimes we hope that it will work quickly. And the evidence did suggest that there are some patients that would respond quickly. But I've also had patients we've just kind of hung in there with them. And then the 6th month where suddenly things begin to change. So there may be patients who the medication failed them early on. They weren't one of those early responders or quick responders, but we're reminding them, they've had migraine for, 10, 15, 20 years, and we probably won't change the biology that quickly. So I think we encourage people to stick with it. Maybe we combine medications, maybe they stay on a medication, and then as Peter said, and all of you talk about too, is what's in the future will come, and those will be something that will offer relief.
I think people ought to understand that I'd say that there's a genuine explosion of interest in migraine. There's a genuine explosion in understanding the biology. And if you can understand the biology, then you can put the pieces together for new therapies. And that's not just like blowing smoke in the air. You can see that's happened. You know, one of the interesting complaints we got, I'll tell you, this is sort of it's not quite out of school, but at the last American Headache Society scientific meeting in June, I heard from one of the organizer people that there was a complaint that there was too much science presented at the meeting. Okay. I can hark back to a day, most of you on the panel will hark back to a day where we could have dealt with the science in the first 2 hours of the first day of the meeting, and then we would have been talking about other things. But, you know, it's an extraordinary statement that headache is in a position where we've got so much going on in the background behind all these developments that you know new things are going to come down the line. So it's not just a kind of patting you on the head saying, oh, things will be better. The science is marching forward. And of course, you know, the American Migraine Foundation is crucial to this in terms of applying sometimes subtle and not necessarily always that subtle pressure to funding bodies, because it's not going to happen by magic and incantation. It's going to happen by research that's aimed at you, everyone on this line who's got migraine or looking after, or if their lives are affected by migraine, investing in the future. And even if one's doing it for one's children, that's all. It's all to the good. So it's not just pipe dream, blue sky saying stuff. There are targets, and the people on the experimental side are driving towards even new therapies.
I think you might be muted again, Larry. I was going to say I could.
You got to get a new chairman, Larry.
I was just going
to the point of not giving up. You know, I harken back to 1993 when I spent the first month with a mentor of mine before I even decided to do headache medicine. So that was what, 28 years ago. And what compelled me to do headache medicine was me watching him back then, when the tools we had were primitive compared to what we have now, and him one after the other, patient after patient, turning their lives around. It was remarkable. And I didn't know any better. I thought, wow, if I go into this field, look how many people I can help. And so think about it. Back then, I had so much hope because of what I was witnessing in front of me, because many other clinics that I would spend time in, there wasn't much hope. There weren't any treatments. And yet I watched this clinician turn people's lives around. So that's what compelled me to go into this field. And just think about it, just to put a point of emphasis on what Dr. Goatsby said earlier. 3 years ago, we had one really single class of acute treatment that was developed 30 years prior. Nothing else since then. I mean, think about it, a disease that was described in 400 BC, we weren't exactly lighting it up when it comes to innovation. And then 3 years ago, we got 3 new molecular targets. We got 6 new drugs. We got another one around the corner. I mean, it's remarkable. And now we have the first disease-specific approach to migraine prevention. And because of, as Dr. Goadsby said, our understanding of the biology of this disease has come leaps and bounds, certainly since I started in this field, and even just over the past few years, where we actually know where migraine begins in the brain. We know where the ignition is. We know the pathways that are activated and become dysfunctional. So we know where the pain is. And we're even now sort of molecularly dissecting out what turns an attack off, where the break is. And so when you understand a disease at the molecular level like that, at least a dozen new targets have been teed up, where drug discovery is now looking at all of these targets in much the same way that we did for the past decade with CGRP. So there's just tremendous opportunity ahead of us now. The tools and the technology we have for drug discovery and for advancing research, as Dr. Goadsby said, the reason why we can fill a whole meeting with research is that that's how much we understand about the biology of this disease now. When you understand the biology of a disease, you can start developing treatments specific for that disease, and we change the entire conversation. So I really believe there's going to come a point in time in the near future when it's no longer going to be acceptable to sit down with a patient, like Dr. Lay said, and say, I have to start you on this antidepressant, or I have to start you on this anti-epilepsy drug, or I have to start you on this blood pressure drug, because I need to jump over these hoops and use medicines that aren't even necessarily approved for the disease we're treating, only to get to drugs that are actually approved for the disease we're treating. So there is going to come a time in the not too distant future where that's no longer going to be acceptable by clinicians or certainly by patients. So just to add my thoughts on and comments on how much hope there is and how much hope patients should have now and in the future. And I'll say one more thing, that I don't think patients quite understand all that we can do for them. Imagine 28 years ago, if I'm watching people's lives be turned around one after the other, imagine what we can do now. We help the overwhelming majority. In fact, I'm going to be bold and say we help every single patient we see. Maybe not to the same extent, right? But there are very, very few patients that we don't help. And sometimes it took me a while to understand that a patient would be walking out of my office with tears in their eyes thanking me. And I would think to myself and actually say to the patient, well, I really haven't done anything. Mm-hmm. Like, you're not even that much better. And that speaks to the patient. What's important to the patient is that they're listened to, right? We have an understanding and an empathy for what they're going through, and we never, ever give up. So they always look forward to that appointment because they come for hope, even if I haven't made a dramatic difference in their headache frequency or in their headache severity. So that's why I say we help almost every patient we see.
Yeah, research is fascinating. I think, Dr. Lay, I think the work that's being done just in understanding, for example, the premonitory phase and beginning to understand how attacks start and some of these interactions with what have been called triggers in the past. I think knowledge frees people. Mm-hmm. And they can take their own decisions from there. But fairy stories are nice for children, but they don't help anybody. I think just as we understand the biology of the problem, and we can explain how that's practical to patients, I think patients appreciate some understanding of what's going on.
Absolutely, and I think work that you've done, Dr. Goadsby, and I'll talk about Dr. Dodick's work in a moment in research, but we're reducing the stigma. Patients now understand that migraine is a brain disease. Mm-hmm. Migraine is not just a headache. And for centuries, for decades, patients have, experienced a lot of stigma, and in their work environment, in their home, it's just a headache. Here I have an over-the-counter medicine to try. You don't look that unwell. I need this report done. Why can't you take everyone to the soccer game on the weekend? You seem fine. And so this research has really advanced our understanding to the point that patients now understand and say, hey, you know what? I have a migraine brain, and it's not just in my head, so to speak.
And I think that exactly. Knowledge reduces prejudice.
Absolutely. And so maybe I'll just touch briefly on the American Registry for Migraine Research, which was really created by Dr. Dodick and also Dr. Todd Schwett, who had this brilliant idea that many have had, but really put it together to say, if we can develop a registry and we can follow patients prospectively, we can also, add to this game-changing science. And so this registry's been in existence for a number of years now with 9 different sites across the United States. And it's very, very comprehensive. There are very detailed questionnaires that patients put into this registry, not just about their migraine and migraine burden and diagnosis, but about their family history, their medical history, medications, allergies, lifestyle, what their childhood was like. Was it a happy childhood? Did they experience trauma, etc.? And all of this information has put in, and there's close to 3,000 patients in the registry now. Close to about 1,300 or so, I think, have also given blood samples. We don't yet have a blood test for migraine, but maybe we will one day. And also 1,900 different brain MRI imaging and CT imaging has been uploaded, images that were just done as part of routine care. So all of this information is available now, and we can apply machine learning to this and put in a couple of keywords and then quickly pull up data from different patients, from different walks of life, from different backgrounds, different races, different skin colors, different whatever it is. And we can really look at the heterogeneity of the migraine patient and find common clues, which will change how we treat patients. And a number of different important studies have come out of this. One I'll just highlight briefly, which won the Harold Wolf Award, which is given for the most prestigious, impactful research in the previous year. And this was by Dr. Ishii, who's a visiting scientist from Japan at Mayo Scottsdale with Dr. Dodick and Dr. Schwett, and really looked carefully at what is this chronic migraine artificial line of 15 or more days per month. You're a chronic migraine patient because you have 8 days that look really like migraine days. But if you're fewer than that, if you have 8 to 14, well, you're episodic migraine. And that dictates medications we're allowed to give. It dictates what insurance companies are willing to cover. And what he found in his research through the American Registry Migraine Research Database is that this is a very arbitrary definition. And individuals who have 8 to 14 days of headache per month are just as disabled as those with 15 to 23 days per month. And so we know it impacts them negatively, their life, their family life, their social life, their work life, their interictal between headache burden, how they're worried, their comorbidity. So it's been incredibly impactful, and I encourage all of the patients, as Dr. Newman was saying, to go to the American Migraine Foundation website, learn about the registry. Right now, it's temporarily on hold until we gather more funding, but we really hope to continue this and move it forward.
Yeah, it was remarkably insightful of Dr. Dodick and Dr. Schwett. How many people with migraine will have an MRI scan just today in the United States? They show very little. Aggregate them together, and we might be able to get something out of that. So why waste everything all these things that are happening, all these expensive things that are happening? If we could channel them back into something that actually will do some good, then I think that was such an insightful moment. And growing that registry is such an opportunity to dig out subtle differences. One of our problems is, while we've got good new tools, we don't have an individualization process. I still find it frustrating. The first day I ever watched my mentor prescribe propranolol in the 1980s for migraine, explaining the side effects and telling me that he really couldn't tell who was going to respond to what. 40 years later, I can't tell who's going to respond to what. So we've got new tools. One of our other challenges, and I'd hope something like a very large registry, as you say, with some judicious use of AI, would enable us to start to narrow down a little bit on, being able to say, well, I think the most likely thing based on your profile is that you're going to respond to this, rather than there's a bit of a smorgasbord of choice. It's a challenge, but there's enough data being generated almost weekly in US medical practice. If we could just harness some part of it, as Dr. Dodick and Dr. Schwett have sort of dreamt about, I think it's a wonderful mission.
Mm-hmm.
Well, I like to think it was insightful or brilliant, but I don't know that I've ever had an insightful or brilliant thought in my life. It was, thinking back in the 1990s. No, seriously, I was thinking to myself a long time ago, much of what we've learned in cardiovascular disease has come from the Framingham Registry. Yeah. Started in the 1950s. It's still going on. It was only meant to be a 5-year registry, and it's still going. And so I thought, what we need is a Framingham study for migraine. What a waste of resources, time, and effort with all of these patients walking through all of our clinics, and we're not systematically collecting the same information on all of them. Mm-hmm. Because no two patients are the same. But yet there are undoubtedly subgroups of patients that, if we could just figure out how to identify those subgroups of patients, we could, for example, to Dr. Goadsby's point, usher in an era of precision medicine in the field of headache. We could, instead of throwing darts with a blindfold, throw a single dart and hit the bullseye on the first effort. Because that's what a registry, when you collect a mountain of data on every single individual, and you're collecting the same mountain of data, whether you're at UCLA or Mayo Clinic or in a community practice in Arkansas or in a clinic in Melbourne, Australia, when you're collecting the same information and you're collecting blood, which you can analyze for biomarkers in blood, or you can do genetic analyses, and you can correlate that with the clinical characteristics of the patient and the imaging. Well, I mean, as Steve Jobs said, the greatest innovations of the 21st century will come at the intersection of biology and technology. And now we have the technology, we have the tools to analyze that, because you or I as human beings could never sort of sift through and analyze and synthesize all of that data, but a machine can. And that's what AI and machine learning is all about. And so I absolutely believe, in thinking about the future, that this is and will continue to be one of the most important efforts in this field. It's proven true in cardiovascular disease. It's proving true in many other diseases, from cancer to other neurological diseases. And I actually think that clinics around the world should be participating in a registry like this. You know, the American Migraine Foundation, let me remind you, also put together the International Registry for Migraine Research. And we were going to launch 2 sites in the UK and 2 sites in Australia, one of which was Dr. Goatsby's site. And we had representatives on this scientific advisory board from 18 different countries, all of whom were very enthusiastic to participate, from Brazil to Korea to Tokyo, all over the world. Can you imagine how this field would change for the betterment of patients if we had a registry like this all over the world? So, yeah, I mean, it takes a lot of work, it takes a lot of money, it takes a lot of effort, but once you hit your stride and once you gather some efficiencies, it isn't really that much work anymore. It can become very automated. So I know that and trust that the American Migraine Foundation will re-kick and restart and reboot this registry, because in terms of the future, I think it's one of the most important things we do.
And it provides education. I think one of the studies showed that 1/3 of women delay or postpone or never think about becoming pregnant because they believe that will have a negative impact on their growing fetus, or they think their migraine may get worse. And so it's taught us that there's a lot more education needed, because of course the vast majority of women do better in terms of migraine during pregnancy. So there's so much innovation that's going to come from this. It's a powerful, powerful tool. We're hoping to start one up in Canada in the next few months as well. So you're absolutely right. The more countries we get involved, the bigger the data bank and the more we can advance science and clinical care.
Yep.
So I think I'm unmuted, but am I unmuted?
Yeah.
Sorry?
Okay, don't do that. So let me just move a bit. And everything you said is spot on. The only thing I would have to take, I would have to disagree with was Dr. Dodick's comment about he's never had an innovative thought in his life. So for our audience, that is the furthest thing from the truth. His innovation has moved the field forward by leaps and bounds. It's clear that registries are our future. It's going to help us with individualized medicine. It's going to help us, as the Wolf Award just showed us, that it's going to help our patients. Those patients who currently are not candidates for certain medications because that arbitrary number of 15, that line in the sand may be changed, opening up these medications to other people in the future. But as we talk about the future, let me just throw it to you, Dr. Dodick. Where do you see research going besides the registry? Where do you see treatment going? We have the CGRP class of drugs out right now. Are there new things? Where do you think advocacy is going? And you can I'm just going to ask you to start us off, David, and then I'll ask the others to put in their opinion, please.
Well, I think about the ABCs of the future, Larry, and 1A is for access. I mean, all the greatest innovations and all the new drugs in the world are not going to mean anything if patients can't get access to them. So, we worked hard on the AHS and the AMF side to ensure that we had at least a practice parameter in place to prepare the runway for these new drugs when they came on board so that patients would actually be able to get access to them. But when I say access, I mean access simply to competent medical care. That's going to require headache education at every level of medical education, from medical school to residency. When I talk about access, I mean access to specialty care for those who need it. And that's going to require training more specialists. And I want to remind our audience that the American Headache Society and the American Migraine Foundation has done a lot. And by a lot, I mean we actually moved this field from having 11 headache centers less than 2 decades ago to over 60 today. So we've come a long way, but we still have a long way to go. Access also in terms of disease-specific treatments. I alluded to this earlier about having to jump through hoops and to having to expose patients to medicines that we don't necessarily think are in their best interest. Not that some of the old oral preventive medications, I still use them today, and we all do, but being forced to use them when we don't think it's in our patient's best interest is not right. And so we need, when appropriate, access to disease-specific treatments, especially when they're in the patient's best interest. I think access also means access to care for all people. And by all people, I mean eliminating healthcare disparities, which has meant that, privilege and opportunity has meant greater access to care or a different level of care. And, we need access to care for the 1 billion people around the world who are affected by migraine, at least to the standard of care. And so, we have a number of initiatives actually that the American Migraine Foundation are involved in to sort of bridge that gap, from the International Headache Society's Global Patient Advocacy Coalition that are implementing workplace programs now. Why is that important? Because most people with migraine are in the workplace. So if we can improve their quality of life, reduce stigma in the workplace, improve access to care, we will not only improve their well-being and their productivity, but improve a business's bottom line. So I think that's important. We are also driving an educational program which Dr. Goatsby will be speaking at in August and in September, where we'll be educating healthcare providers in sub-Saharan Africa, trying to sort of raise the level of education so that they're able to care for people with headache that they're seeing. That's access. So I'm optimistic, but we have a long way to go, but we have to improve access for everyone. The other A here is for advances, and by that I mean advances in treatment. We've talked about the CGRP drugs, unquestionably a tremendous advance, over 1 million people treated in over 50 countries around the world, and we're just getting started. But unfortunately, they don't work for everybody, as we've already said. But I can think of at least 12 new targets with drugs that are either in phase 2 or drugs that are being explored right now. The most proximal, or the nearest one, is probably one that targets a protein like CGRP called PACAP. And probably there's as much circumstantial and preclinical and clinical evidence that supports PACAP as being equally important as perhaps even CGRP in triggering migraine attacks. So there is a biologic, an antibody that's been developed that will target that protein, and hopefully someday, very soon, it will be as safe and effective as the 3 antibodies that are available that target CGRP right now. So I'm optimistic, and others are optimistic as well. So I think that the future looks bright in terms of treatment advances. We talked about the registry. I mean, developing a biomarker, whether it's a clinical biomarker, a genetic biomarker, a serum biomarker in the blood, that will not only allow us to select the right treatment for the right patient, but also allow us to have a prognosis for a patient, because some patients go on to develop headache every single day and every waking moment of every single day. Who are those people? So we can intervene earlier. So having a biomarker that predicts who's going to progress and who's going to develop some of the comorbid diseases that people with migraine have, whether it's irritable bowel or fibromyalgia or depression or stroke, who's going to develop these complications or these other comorbid diseases? That's really important to know, because if we knew that, we could intervene early to prevent that from happening. So I think identifying the biomarker is going to be really important. And then finally, the C here is stigma. Now, stigma begins with an S, so that doesn't make much sense, does it? And it doesn't make any sense. Just like it doesn't make any sense why people who have had every aspect of their life impacted by the world's most common neurological disease, they've been under-recognized, untreated, and stigmatized as having a condition that is at best psychosomatic and at worst made up or exaggerated. And that has to stop. And unfortunately, I think we're turning the corner and we've moved a needle. It also doesn't make any sense, by the way, why those of us who choose to pursue a career in headache medicine have had things said to us like, why would you waste a perfectly good career on something that's not even neurological? I mean, believe me, that and many other things have been said to all of us, I think, and I still hear them today, young people coming in who choose to do a fellowship in headache, what they're told by others in the field. It's staggering, but I'm hearing it less and less. So I believe with advances in treatment, the patient's voice has to become more prominent. And with advocacy groups around the world rising up, things are moving in the right direction, and we're seeing more funding for research from organizations like PCORE and from the DoD. More doctors and advanced practice providers are becoming really interested in pursuing research or clinical careers in headache, like Dr. Goadsby said. I have students now in their first year of medical school coming wanting to do headache. I mean, that was unheard of before. And so my message to the patient is to advocate for yourself. Find a clinician who understands, who is empathetic, who doesn't and won't give up, and who will find the best treatment approach for you. And don't give up until you find that person. And also get involved with advocacy groups, of which there are a number in the United States. I think the American Migraine Foundation is certainly one of the largest and best established. So I would encourage you to do that, because you need to stand up for yourselves and you need to come together and mobilize. And I would say get involved in research. I will tell you that patients are increasingly sought after right now to be intimately involved in the design and in the conduct of research. And I firmly believe that the way we measure success of new therapies will change over time in the not too distant future, I believe, as patients work with researchers to define what success looks like and how should it be measured. Because I am not certain that we've been measuring it the right way. Ironically, let me tell you that the way we measure success in clinical practice is at the bottom of the list when it comes to clinical trials. So we measure responder rates and monthly reductions in migraine days in clinical trials. What do we measure in clinical practice? Patient satisfaction, right? Their global impression of how they've changed. Are they better? That's what we measure in clinical practice. And I can tell you that's at the bottom of the list in clinical trials. So I think patients are going to set us straight on what we should be measuring in clinical trials and how best to measure that.
Thanks, David. Peter, we're talking, since this is the American Migraine Foundation, we're talking about patient advocacy, but I think we all need to tip our hats to the American Headache Society, because the professional advocacy that your organization is in charge of has really helped move the needle. And as that needle moves for physicians, it clearly impacts the patients in a good way. So if you could if you have a second or a couple of minutes, just to let the audience know what you're doing.
Oh, I'm glad you think that. The American Headache Society advocates is looking to the future in a number of ways. One of them is training. As Dr. Dodick said, there are more than 60 now, programs throughout the country. And there was a time when there were more programs than there were applicants. So it was a little bit of a Wild West. Well, still a bit of a Wild West, but there are now more applicants than there are programs. At one level, that's a bit stressful, because that means we can't train everyone who'd like to be trained. But at another level, it means that the change, the wish to go into headache medicine is really changing. So the American Headache Society is quite invested in that. We're invested in attracting residents. It's my general experience that the earlier you get to the residents and students, as Dr. Dodick, Dr. Lay, I think would agree, that you sort of bind them in to the headache world, because it's a good field. It's interesting. The biology is great. You can do something for patients. I mean, it's a really great field to be in. If you can show young folk that, they stay in the field. I think if you can get a resident into something, you're going to get a 30-year return. Tell me what you buy today is going to still be useful in 30 years. Not much, maybe a stone out in your garden, but not a whole lot of stuff's going to be there in 30 years. So that's a great investment. We're heavily invested in residents. And of course, as you say, we've partnered with various groups over the years to try and advocate directly with Congress in Headache on the Hill. And if anyone has an opportunity to support that, go and pull the chain of these people who are making spending decisions. It's your taxpayers, for God's sake, pull the chain and get a result. And the other thing I think that's important for us is in the context of leadership and developing new folk. We have the same fundamental interest in diversity, equity, and inclusion as you said, because if it's not fair at every level, it's not fair. And that's very straightforward. It's a simple thing to say, but changing it so it is fair is quite something that the AHS has seized upon the need of doing. We want to be able to provide the underpinning support, research-wise, relationship we're building, I think, better now with the National Institutes of Health, National Institutes of Neurologic Diseases and Stroke, the NINDS, for research. We're teaching and, of course, maintaining our members so that they can serve the patient needs better. So we're trying to get across what we can do, and I'm grateful that you think it's useful.
It's definitely is. David, did you want to say something?
I was just going to say one more thing about the future, and I'm saying this for the patient's, for the patient's benefit, and that is that the word early is going to become increasingly important for the treatment of migraine. We now have the tools to be able to safely and perhaps effectively treat patients, not just their acute attacks, but also prevent them from progressing. So I think early treatment of an acute attack, instead of whack-a-mole, like chasing an attack after it's already started or a headache after it's already started. Imagine if people recognized that prodromal phase before their pain actually begins. We now have medicine that not only shouldn't cause rebound, but might actually be effective during that prodromal phase. So I think the earlier we can treat an attack, the better for the patient. And I think the earlier we can treat the disease, the better for the patient, so that patients don't progress from this time when they're having a few attacks a month or a few attacks every other month to a time when they're having a few attacks a week or an attack every single day. So early intervention, both at the level of the attack and at the level of the disease, is going to be increasingly important as we move forward. So keep an eye on this space, because I think it is the future.
Excellent point. Christine, do you have any final comments?
I'm just going to add one quick comment. I think that AMF and AHS are a beautiful partnership. And so, as Dr. Dodick said, you have to advocate for yourself and find a clinician or provider. And if you find one that was unfortunately not trained well, not by their own fault, but really by the fault of the system, it's not well taught in medical schools, and we're working to change that. But you can get your own information from the AMF perspective as the patient, and you can encourage your clinician to go to the American Headache Society, because there's a beautiful program there for primary care practitioners so that they can learn about headache medicine and how to treat and approach patients. So it's a great partnership for everyone, I think.
Yeah, I agree with everything you said. I think we're coming to a close, so I'd just like to thank the speakers this evening. Your comments were spot on, they're informative, they were inspiring, and I've got to admit, not only did you make this easy to moderate, you answered my questions before I had the chance to pose them. And I'll also admit that I too I'm anxiously awaiting to see what our future holds for us, and by extension, our patients. We saw through your comments how advances which started in the laboratory, although it took time, now have made it to the pharmacies and are helping us improve the way we care for our patients. We've heard that there are many things coming down the pike. But as you've seen, it takes time, and more importantly than taking time, it takes a village. There's all of us, either as professional, as clinicians, as patients, as patient advocates, as professional advocates, we all need to come together. We saw the importance of ARMR, the registry, which unfortunately is on hiatus now due to funding, but we're part of my role as chair and Christine's as vice chair is to get that registry up and running again. You know, so as much as the basic science work is important, as much as our patient care initiatives are important, it's only part of the puzzle. Equally important are the conversations that Dr. Goadsby just alluded to, those conversations that happen out of our site. They happen in community support groups from our patients. They happen in the hallways and in the offices in Capitol Hill from the professional level. And what I'd like to ask our attendees, our audience, even though this is Migraine and Headache Awareness Month, June, ending today, our efforts will not stop in June, and we'd ask you to continue with your efforts. You can help us in any number of ways, grassroots or helping us through your support of the foundation. Just thinking as I'm listening to these three wonderful people speak, if 900 of you, or more than that now, who are signed on, reach out to several of your friends and your family members and your coworkers and tell them about the importance of the foundation and the work that we do for you and the people that you care about. If each of you could corral several people, many people, and each of them donate, rather than you donating, organize a grassroots effort to donate, we can get this registry up and running in no time flat. And who wins? We all win. So with that, let me just say, you know, I want to thank the audience for signing on. I want to thank our speakers for their insights. And we, again, AMF, AHS, we all welcome our collaboration. We welcome your involvement. And as we've said, you know, if we all stand together, no one will stand alone. So thanks again, everyone.
Thanks, Larry.
Thanks, Larry.
Thank you.